Good morning. Once again, my name is Neil Mitra. I'm from Mount Sinai West. I'm here to talk to you guys about ESD and the benefits of a mechanical high-pressure punctureless endoscopic lift system versus the standard sclerotherapy needle in the ex vivo bovine colon model and why it's important. These are my disclosures. Okay, so in order to understand the importance of the lift, we have to understand why we do it in the first place. So around 28,000 patients each year undergo partial colectomies for sessile benign polyps. So patients who undergo the ESD and EMR methods of removing these polyps get to avoid this invasive procedure. Now, the submucosal lift is critical for this procedure to be successful. And the target layer for the lift is what we try to expand when we do ESDs and EMRs. Here's a brief walkthrough of an ESD. So you'll notice the lesion is oriented at the top here. And then we generate a submucosal lift via an injection to generate the lift. And then we use a dual knife to score the base of the lift and then excise the tissue through dissection with the scope in the submucosal layer. And then we do this until we remove the tissue. So bowel wall lifts are important because when you use a needle knife or a snare, there's a high risk of getting into the deeper layers. So the submucosal lift helps to separate the mucosal layer from the deeper muscle and serosal layers, which is important to prevent deeper damage to colonic tissue. So the methods of injecting the bowel wall include the sclerotherapy needle as well as the high-pressure punctureless systems. You can have a high-pressure catheter, but there's also combination high-pressure knife combinations that can be used in the market today. So with the sclerotherapy needle, what you end up doing is you need a strong amount of force to puncture the mucosa. So what ends up happening is that you fold the mucosa as you try to inject the needle, and then you have the needle ending up in a deeper layer than intended. So what ends up happening is that as you inject, you have to slowly withdraw the needle until you're injecting into the correct layer, the correct space. And this leads to fluid or lifting solution going into unintended layers, therefore diminishing the quality of the lift. What can also end up happening is that you'll get these deep bowel wall lifts. What happens is that you end up expanding the incorrect plane. It could be the subserosal or muscularis propria plane. And when this happens, you end up dissecting the incorrect plane, which leads to a much deeper than intended dissection and therefore further laparoscopic repair if needed. So this is actually an example one of our investigators faced in a clinical case, and it actually helped inspire this study, where during injection, they thought they were in the intended submucosal space, but they ended up being in the subserosal layer. And what ends up happening is that you have a much weaker bowel wall that then immediately needs to be repaired laparoscopically, which is what happened in this case, versus the intended submucosal detachment, which is the ideal for the ESD. So with the high-pressure punctureless method, you essentially just have to have the catheter touching the mucosa. There's no needle, there's no injection other than the fluid. And you simply have to place the catheter tip on the mucosa then lifts, and then you simply adjust the catheter as the mucosa lifts so you don't push the catheter into the mucosal tissue through the jet. So what we end up seeing is that even with the high pressure system, we do get deep lifts. So the question we asked ourselves is, compared to the sclerotherapy model, is it less likely to occur? Because we see that these deeper lifts do occur secondary to the primary submucosal lift. So here's some good videos. So some characteristics we qualified as good when it comes to lifts is that you have these round, well-demarcated, tall lifts, and the dye that you inject can be easily visualized. And then here were some characteristics we determined to be poor. So we ended up being with these long, deep, diffuse, more or less tall, with the dye being less apparent post-injection. So our initial hypothesis is that the punctureless method would commence lift generation in the submucosa at a better rate compared to the sclerotherapy needle, and help us establish the lifts where deep lifts would be less likely. This is the model we use, the ex vivo bovine colon model. We got the colons the same day. We would clean them. We try to use them the same day if possible, and we'd do an equal number of lifts per modality, and then open up the colons for evaluation, and then cut out each lift for histological evaluation. The lifting solution we used was 1 parts tissue marker dye, 500 parts saline. We used tissue marker dye for better histological evaluation so we could see where the lifting solution went in the layer. We used the sclerotherapy needle as well as the Irby jet for the machine pump high pressure method. Lifts were visually assessed in 3 categories: the initial appearance, the general shape of the lift, as well as the final impression. The colons were then cut open lengthwise, as said before, they were evaluated and then sent for sectioning for histology. We ended up using 7 colons. We tried to use them 8 to 48 hours post-harvest. With the sclerotherapy technique, we ended up with 103 lifts. With the high-pressure technique, we ended up with 99. Here's some of the colon pelts post-injection. You end up seeing that the sclerotherapy lifts tended to be these wider, broad, deep lifts, while the high-pressure techniques tended to be well-circumscribed. We tended to use different dyes from week to week. Here's a more focused look at both the sclerotherapy needle and the high-pressure methods. Sclerotherapy needle, you would get superficial, well-circumscribed lifts, but they tended to be wide and deep, versus the high-pressure. You'd see some deep lifts, but they tended to be less pronounced. Here's some quick histology. This is what we intended to see, or ideal, with the lift being in the submucosal space, versus what we actually saw in most of our lifts, that there were deeper muscular elements. And this was due to the fact that we're dealing with dead bovine tissue, so it was likely that there was weaker connective and muscular tissue, which ended up with lifts in both the submucosal and the muscular space. Our initial lift impression, we saw that the high pressure technique tended to always give us a superficial lift, while the majority of the sclerotherapy injections ended up being deep. With regards to the shape of the evolution of the lifts, again, the high pressure lifts tended to be round and well circumscribed, while most of the sclerotherapy injections had deeper elements, cigar or cigar then round. The final lift impression tended to be superficial for the high pressure technique, while the sclerotherapy technique ended up having these deeper elements. Surprisingly, despite the gross elements looking superficial, most of the lifts we attained ended up having mixed elements of superficial and deep, meaning submucosal and muscular. Comments regarding the ex vivo bovine model: it's dead tissue colons, so it degrades pretty rapidly. The strength of connective tissue weakens, which is why the muscular propria layer is more likely to expand. Clinically, it's likely that the deep lift incidence will be lower. And then I'm just going to quickly wrap up, as I'm short on time. The 2 pathways of lift generation we notice is that you can either get deep to submucosal, which we really only saw with the submucosal method, versus submucosal to deep, which we generally saw with the high pressure method. And then this pretty much says the same thing. We only saw the deep to superficial flow with the sclerotherapy model versus the high pressure, which tended to be superficial to deep. In closing, mixed lifts were very common in the ex vivo bovine model, again, because it was dead tissue. Histological results showed or echoed the same thing due to poor tissue integrity, but visual grading gave a clear advantage to the high pressure methodology versus the sclerotherapy technique. So it would more likely be the case that with the high pressure method, you'd expand the submucosal space, which is ideal for ESD and EMR. Thank you.
Thank you. Are there any questions from audience?